And Phil and I really benefited from Phil's experience when we were both starting. And he used to come to London and he used to give me tips and tricks. And I used to go to Sydney. It was always a very good excuse to go to Sydney. And again, he would give me tips and tricks. We'd share experience. And I think we both benefited of that. But I'm extremely grateful for Phil's advice over the years and support over the years. It's been a really good relationship, but I really look forward to hearing his latest data, and particularly, and this is one thing that I think he does, he's probably pushing the envelope in terms of being very aggressive in terms of treatment near the sphincter, and I'm particularly keen to hear how he manages that. Phil, welcome.
Bart, thanks, Mark. I'm going to let Bart Gerbers, our fellow, give our latest data. And then I'm going to give our latest data on IRE, but it's a pleasure to be part of the audience.
Thanks, Prof. Thanks, Professor Emberton as well. I'll start sharing my screen to show you the slides we've prepared. I'm Bart Verboers. I'm Professor Strick's Research Fellow indeed. And I'll present to you today our series of localized prostate cancer patients that were treated with IRE in the primary setting. These are the disclosures. We performed a retrospective analysis of a single center cohort, all patients treated at St. Vincent's Prostate Cancer Center. And we aimed to determine the functional and oncological outcomes of all patients with localized prostate cancer that were treated between December 2013 and February 2022 with a primary IRE. And we allowed one redo treatment within that treatment protocol. And then the primary outcome measures that we looked at for this analysis were the presence of significant prostate cancer 1 year post-treatment on transperineal mapping biopsies, and the quality of life, including urinary and sexual function. We selected patients with unifocal localized prostate cancer that had an ISUP grade between 1 to 4 and a positive lesion on MRI. And of course, there needed to be a good co-registration between the MRI imaging and the biopsy lesion. PSA needed to be lower than 15. And that brought us to a total of 348 patients that were treated at St. Vincent's for focal prostate cancer. We excluded 82 of those that were treated in the salvage setting, and another 22 that had a shorter follow-up than 6 months, which brought us to a total of 244 patients that were enrolled in this study. 86% of those patients had an ISUP score of 2 to 3, but the majority of those had an ISUP score of 2. And redos were performed in 26 patients, so it was about 10%. The ablation field covered the entire hemigland in 13% of patients, and the entire prostate quadrant in 37% of the patients, and smaller fields in the other half of the patients. And it's important to tell that the ablated prostate regions in this cohort covered the apex in 67% of the patients, and the midgland in 77%, the base in another 66%. And also the anterior part of the gland was covered in 38% of the ablations. So this already shows quite good that IRE was performed in all prostate regions in our center. To start off with the safety of the treatment, we did not experience any major adverse events in this cohort. No rectal fistulas did occur. There were some low-grade adverse events like dysuria, hematuria, some perineal pain, but they were all reversible and minor. And then go straight to the oncological outcomes. At 12 months after treatment, on imaging, 92% of patients had an MRI in their follow-up at 6 to 12 months after the IRE. And the MRI was clear in 86% of those patients. 8% of the patients had an infield suspicious lesion on the MRI, and 6% of those patients had an outfield suspicious lesion on the MRI. But then the transperineal template biopsies that were performed in 76% of this cohort showed that 83% was clear, actually, and that only 3% of the patients had an infield significant lesion that was defined as any ISUP score of 2 or higher. About 14% of the patients had an outfield recurrence of significant prostate cancer. And then is the IRE adequate to follow up patients after NanoKnife? As you can see, we compared the template biopsies with the imaging at 6 to 12 months, and we found that the MRI actually has a pretty low sensitivity for recurrence, and it missed about 30% of the lesions that were found of having significant prostate cancer on biopsy. And those undetected lesions mostly were low volume ISUP2 lesions, but about 30% of those lesions still had an ISUP score of 3 or higher. And the majority of the lesions were quite small, smaller than 0.2 milliliters, which reflects MRI's dependency on lesion volume, which we know from other studies as well. Then the oncological outcomes overall, we had a median follow-up, overall follow-up of 50 months. And after those 15 months, 84% of patients were free of radical treatment. 28% of 28 patients progressed into needed a radical prostatectomy. 10 ended up having radiotherapy. And we only had one patient that eventually metastasized, bringing us to a metastasis-free survival in this cohort of 99.6%. And the patients ended up having hormone therapy. He wasn't monitored very well. He refused any MRI or biopsy or PSA follow-up. And that's how that ended. Then we calculated a failure-free survival. A 5-year Kaplan-Meier estimated failure-free survival that we found was 79% of failure-free survival at 5 years. And then those patients that progressed, locally progressed, that needed salvage treatment, eventually salvage whole gland treatment. We performed the sub-analysis that was recently published in BMC Urology, of a cohort of 15 patients that received a radical prostatectomy with a follow-up of 22 months. And we found that cohort was that none of those patients experienced rectal, bladder, or urethric injuries. And only one patient had positive margins on whole mount pathology. None of the patients had biochemical recurrence at 22 months, and all of them were PET-free, had PET-free continence after 6 months, and about 60% were potent after 6 months. So I think this is actually quite a remarkable series, and it shows that salvage prostatectomy post-IRE is feasible and can be done with good oncological and functional outcomes. But then the functional outcomes after IRE, we had about 2% of patients with incontinence at baseline, and 3% of the patient, and 2.3% of the patients with having incontinence at last follow-up. So a slight raise of 0.3%. An erectile function that's sufficient for intercourse. About 70% of patients were having sufficient erections at baseline, and that deteriorated by about 10% at last follow-up to 16%. Looking at the validated questionnaires we used to assess the functional outcomes, we found that the treatment is actually very well tolerated by patients with very little physical impact. As you can see, the only questionnaire that score that deteriorated was the EPIC sexual summary score. We also look at risk factors to develop erectile dysfunction or urinary incontinence, but other than age being a predictive for or the development of erectile function, none of the other risk factors proved significant at baseline. And it's important to say that we found that the treatment of the extreme apex in this setting is safe, and it's treatment of that area is without any difference in quality of life outcomes compared to other areas, which was recently published by our group as well. And then looking at risk factors for local recurrence at 12-month biopsy, the only predictive factor here was the highest percentage of patent fall in the baseline biopsy. And there was a trend for significance for the ISUP score at baseline to be predictive for local recurrence at 12 months, but none of the other baseline characteristics were. And then I think, probably the big question here would be, this is a good series, it's a large series, but are these results translatable and replicatable in other centers? And as it happens, this series from Dr. Jaxley from Brisbane, Wesley Hospital, has just been accepted for publication. Dr. Jaxley and his group were tutored by Professor Stricker, and they've now treated about 70 patients in 3 years, with a median follow-up of 23 months. And among those were 50 primary IRE patients with more than 12 months follow-up. And as you can see, they had a 87.5% of those patients were clear of significant prostate cancer on 12-month biopsy, and about 86% had sustained erections, and the entire cohort had sustained incontinence. When you compare those results to the results from our center, you can see that they're actually quite similar. We had a total percentage of patients being clear on biopsy, which means infield as outfield together, of 83%, and 90% sustained erections, and almost 98% of patients that sustained continence. So it looks like these results are actually transferable and translatable to other centers when tutored in the right way. So to conclude, I think we can say that focal IRE in the primary setting is safe with minor and reversible complications. In our hospital, we found only a 0.3 percentage point additional urinary incontinence at last follow-up, and erections were unaltered in 90% of the patients at last follow-up. The quality of life outcomes are the same for all the treated prostate regions. So in our experience, it's safe to treat the extreme apex as well. We found a 5-year estimated Kaplan-Meier failure-free survival of 79%, and a total metastasis-free survival of 99.6% at 15 months follow-up. Of course, there's still need for long-term comparative outcome data before definitive conclusions regarding oncological safety of IRE can be made compared to whole gland treatment. But I think that this series that appears to be replicatable shows very well that IRE is well able to avoid, or at least defer, the morbidity that is associated with whole gland therapy. Thank you very much.
Thank you very much indeed. We're being squeezed for time. We're right up to time now, but maybe you'll take some questions from the audience. So thanks again for giving up your evening. We're just starting our day here, so much appreciated. Any questions? There was nothing on the Slido that I'd left down on my chair. Any questions for Phil? So,
make one
Yep.
comment? Can you
Yep.
hear me there?
Go ahead. Who's got a? I can't see.
I just need to thank you, Mark, for taking me on in 2012 and teaching me how to treat the front of the prostate. Because you told me originally that the back of the prostate was for HIFU and the front was for IRE. And I slowly crept down into the back of the prostate over time. And it's been an interesting to and fro learning curve between you and I across the world as to how we've sort of dealt with all these things. So I have to thank you for taking me on.
No, that's great. So can I ask you a question while we're getting lined up? Is tadalafil use a risk factor? So if you've got good erections, I give the same advice as you get, 90 to 95% chance of keeping erections. I don't know what to say to the guy who maybe has mild diabetes and is already using tadalafil. Have you got enough cases to model that?
We do, but the definition of impotence was based on answering yes to question 3 in the IIEF, which means that you can have intercourse most of the time with or without a tablet. So I think that in my experience, people who are on tadalafil are slightly more at risk, but we haven't done a subgroup analysis of that. I would guess that it's more than 10%.
Great. Okay, we've got a question.
Hi Bart, Geboers and Phil. This is Theo de Rijken from Amsterdam. What I saw during these presentations is that the recurrence rate in Australia and Korea is much lower than here in the western part of the world. And I learned from Matthijs Geltema, who was also a fellow with you, Phil, that you became more aggressive in treating the tumor. Do you see during your curves that the tumor control improved?
You're very, very wise. The answer is yes. Since I've gone to becoming more aggressive, and I call it going from a lesion to a region, I've had more success and I've pretty well got rid of local recurrence, but not outfield recurrence, because that's more a patient selection issue. But the one thing I have noticed is the wider you go, the more retrograde ejaculation you start developing, something that hasn't been reported in our group yet. And it occurs at about 3 months after the ablation. And it's a bit like you're causing so much damage to the prostate, it retracts and then they develop this retrograde ejaculation, something I warn all my patients about now. And that's only occurred since I've become more aggressive. So it's not causing more impotence, but it's causing more retrograde ejaculation. Indeed, the AUA symptom score is improving. It's like doing a resume on a patient at the same time. So my answer is, yes, I've got better in-field control. I've got, with better patient selection, we're managing to get better results. And I think that's just experience and possibly PSMA PET scanning as well. And finally, it's causing more side effects with retrograde ejaculation.
Raphael's just got us a question on Slido, and this is about in-field control. So he's asking whether you can double treat. And I'll just modify the question for time. Are you using a longer cycle now? So this is a bit technical, but with IRE, you can choose how many cycles you expose the prostate to. The more cycles, the deeper the injury, and also the wider the injury. So are you getting a bigger lesion through more treatment, or through wider spacing of needles, or both?
First of all, I'd just like to congratulate Bart on a good presentation. But as far as the actual treatment goes, I've copied you a large amount of the time, Mark, and I do a run of 10 treatments first to make sure my electrical parameters are correct. If they aren't, I do another 10 and then do another 80. If I use more than 4 electrodes, I do double treatments in some of those, where you might imagine there's a box and a triangle, for example, if you've got 6 electrodes or 5 electrodes. I will sometimes do the electrode, which actually goes across the same field again, which I never used to do as a matter of security. So yes, I'm erring on the side of double treating, but it's not my routine.
Okay, so this is important. Cryotherapy has been pretty much standardized, minus 40 times 2. IRE hasn't yet been standardized. Everybody does it slightly differently. Phil and I do it very similarly, actually. But actually, if you speak to people, everybody's got a slightly different kind of signature in the way that they administer the voltage. I think we're kind of out of time. Is there one more burning question before I thank our Australian colleagues? No. Phil, could I thank you both? Bart, wonderful presentation, great work. Thank you for giving up your time and sharing your experience with us. Look forward to seeing you in person, Phil.
Thank you.
Thank you. Bye-bye.
I think we've learnt that the learning curve is now discoverable. We just need to work with colleagues, and it can be replicated very easily. So there's no fear about that. And like with most things in surgery, that with experience we can continue, and indeed have to continue, improving the outcomes, both functionally and oncologically. So could I thank all the speakers for fantastic presentations, a really great session in which I've learnt a lot, and thank you also for the questions that we've had.